All right, I'm very happy to introduce Dr. Jamaal Benjamin, Assistant Professor of Radiology, Vascular Interventional Radiology Division at UT Southwestern. Dr. Benjamin earned his medical degree and Ph.D. in Molecular Microbiology at UTSW. He completed his Diagnostic Radiology Residency and Advanced Fellowship in Vascular and Interventional Radiology at the University of Pennsylvania. And his research interests include cancer biology, the response of hepatocellular carcinoma to liver-directed interventions, which he'll talk about, autophagy and oncologic diseases, and innovations in lymphatic imaging and interventions. Please give a warm round of applause to Dr. Benjamin.
Wonderful. I guess it's good morning or good afternoon, but so great to meet everybody. As Andrea said, my name is Dr. Benjamin, and I'm one of the interventional radiologists here at UT Southwestern. And I work closely with Dr. Shea, Dr. Singhal, Dr. Chowdhury, and Dr. Rich. So we all work together as a team. And so I think that's a common theme today. It's like it's definitely a team sport. Okay, and so just by way of introduction, again, my name is Jamaal Benjamin. I'm one of the IR physicians at UT Southwestern. I also take care of a lot of patients at Parkland Hospital as well. But I like to think of myself as some homegrown talent. I did medical school here at UT Southwestern, and that was the combined MD Ph.D. program. So I spent 8 years here at UT Southwestern. And then after that, I spent a year at Methodist Dallas, where I did a year in general surgery. And then from there, I transitioned up to Philadelphia. So I was in Philadelphia for 6 years, where I did my diagnostic as well as my interventional radiology training. And then being married to a local Fort Worth girl, we came back to Texas as quickly as we can. So we've been back in Texas since 2022. We really enjoyed our time here. And like Dr. Singhal mentioned, it's a really unique place to do interventional oncology, which is kind of what we call this portion of IR, where we treat a lot of liver cancer patients. So as a common theme this morning, so what is liver cancer? So, the liver helps digest our food, store energy, clean the blood. But as we know, liver cancer is when the cell growth in the liver actually kind of gets out of control. And so, as I mentioned before, the most common type of liver cancer is going to be HCC. So, why do we need local treatment? So Dr. Rich did a really nice job of explaining, oftentimes, the goal is going to be, to do a surgical resection or do a transplant, but oftentimes, as Dr. Singhal described earlier today, surgery or transplant isn't always an option. So, a lot of people know about chemotherapy, but chemotherapy is going to give, medication throughout your whole body. But really the nice thing about interventional radiology and the thing about what we're doing is that we want to treat the disease right where it's at. So we want to treat the disease focally in the liver. Either that's through going through the skin and treating it with an ablation, or that could be with intra-arterial chemotherapy. Okay, so that's where we go inside of the artery, go to the blood vessels, giving blood supply to the tumor, and deliver a high dose of chemotherapy or radiation therapy directly to the tumor. So the idea behind that is we're going to minimize the systemic side effects, because we're not giving treatment throughout the whole body. We're only giving treatment to that focal area within the liver, okay? And because we're doing it like that, and because we're doing it minimally invasively, we can treat a lot more patients than necessarily can be treated with a big surgery or a transplant, because we're only treating a specific area of the liver. So by, I guess, just kind of polling the audience, how many of you guys have ever heard of an interventional radiologist before? Wonderful. And so I think the setting that most people see interventional radiologists is typically they have a loved one who has some sort of cancer diagnosis and they're getting a port placed, or they have some sort of mass that they need biopsied. So oftentimes that's how we are interacting or interfacing with patients first. But interventional radiology is this new emerging field. We're really at the intersection of both imaging and procedures. So a lot of us have done formal training in surgery. We get formal training in radiology as well, understanding how to read the CTs, the MRIs, the ultrasound. And then we get advanced training actually in the procedures itself. So that's learning how to do an ablation or to do a chemoembolization. So we work closely with doctors, but the key thing with IR is we're doing all of our procedures with image guidance, okay? So the fact that we're using image guidance lets us do it minimally invasively. So this is kind of just a picture of, an IR doc in the IR suite. So a lot of our procedures are done with fluoroscopy, what's called X-ray guidance. So we're going through a small incision that can be in the groin. Oftentimes, we're going through an incision in the groin, and we're using a combination of wires and catheters and X-ray contrast dye to work our way to the particular blood vessel that we want to treat, okay? So as Dr. Rich mentioned, oftentimes there's criteria for when people can get liver transplants, right? So, but not everybody's going to fall within that criteria to be transplanted. So a big role for IR is we are what we call a bridge to transplant, okay? So oftentimes what we're trying to do is downstage the liver cancer to get them within criteria where they can actually get a liver transplant. Alternatively, some patients, for a lot of different reasons, may not be candidates for transplant. So what we want to do is treat all of the disease we can in terms of increasing overall survival and minimizing the burden of the disease that they have in the liver, okay? So I just want to show you guys pictures because I'm a radiologist, and so if I don't show pictures, it just wouldn't feel right to me. But I want to show you guys a couple of different procedures that we do, right? So this was a gentleman, we actually did 2 different procedures on him because he had 2 different tumors here. So you can see here on the right hand of the screen here, you can see he's got a larger mass here, which is a tumor that we treated with radiation therapy, but he has a smaller mass adjacent to it that we end up treating with microwave ablation. So what I'm showing here on the right is you can see we've actually have our ablation probe going through the skin, okay? And we're using CAT scan guidance, so we're advancing the probe all the way into the liver, through the skin, into the area where the tumor was, okay? So we're doing all this with CT guidance, we're doing CAT scan guidance, and we literally incrementally, centimeter by centimeter, work our way till we get into the tumor, okay? Once we've confirmed our position with image guidance, we then do the ablation. So what we do here is this is the tip of our ablation probe, so we burn all of the tumor in that area, okay? So all of the tumor in that area is completely dead. And then we even cauterize our tract on the way out, okay? And what that does is minimize the risk for bleeding. And amazingly enough, this patient goes home the same day, okay? So we treat that whole tumor the same day. We get a follow-up MRI in 3 months, and we see this whole area is dead. And so hopefully the goal is, and I often tell patients, we'll be here for you if you need me, but my goal is to get you to transplant, okay? So the goal here is to get that tumor under control where now the patient is a candidate and he can then go for transplant, okay? So depending on the size of the tumor and the location of the tumor, just like Dr. Rich said, so some patients are amenable for ablation, other patients have to have intra-arterial therapy. So there's a couple different ways we can treat these tumors from inside of the artery. So one of these ways is what's called intra-arterial chemotherapy or transarterial chemoembolization. TACE is the big word here for it. So what I'm showing down here, and you see the circle here in this red circle, this gentleman had a 3.2 centimeter mass here in the inferior lobe of his liver, okay? And so the first time I actually saw one of these procedures done, I was a 4th-year medical student, and it felt almost like magic because the patient is awake, okay? So what we do is we go from inside of the artery, we work our way all the way inside the artery, and we snake our way. You can actually see right here, this is the tip of our microcatheter here in the liver, okay? So we have our catheter all the way out to the small 2-millimeter artery that's giving blood supply to this tumor, okay? And then what we're able to do is we're able to give a high amount of chemotherapy directly to that tumor. So we give the chemotherapy to the tumor, and then we give some small particles behind it. So we're giving chemo, and then we choke off the blood flow with the small particles, okay? And again, this is done with a centimeter incision in the groin. And oftentimes the patients are awake, and we can even pull up the monitor, and the patients will watch as we're doing the procedure. And it's mind-blowing. The first time I saw it, it's truly like revolutionary because these people are awake and they can go home the same day again. So we're treating this with chemotherapy, and we can give a high amount of chemotherapy directly to the tumor. And and they don't have any of the systemic side effects. So they're not going to lose their hair. They can tolerate the procedure much better. Their fatigue is much lower, but we're able to get a very good treatment in here. And hopefully she can go on then to get a liver transplant. So again, on the theme of minimally invasive procedures, we can do the same thing again, but sometimes instead of giving chemotherapy inside the arteries, what we do is we give high dose of radiation. So the procedure I'm showing here is what's called transarterial radioembolization. Sometimes you'll hear it called Y90. So what we're doing here is instead of giving the high dose of chemotherapy directly to the tumor, what we're doing here is giving high dose of radiation therapy. So again, you can see, the patient is awake during this procedure, but we've worked our way from the aorta into the big artery that's giving blood flow to the liver. And then we've even gotten more selective. So again, we're out here in this tiny 2 millimeter branch of the artery that's feeding that tumor. Okay. So you can see the tumor is highlighted here in white, this big white mass here. And then from there, it shows you where we position our catheter to give that high dose of radiation. And then this is this 3-month follow-up. And so you can see that whole tumor is completely dead. So that 4-centimeter tumor is now completely gone. So now this person is now in criteria where he could hopefully go on to later then get a transplant. And again, these are done on an outpatient basis, minimally invasive, a small centimeter incision through your groin, right? So the technology is really it's improved so rapidly that these patients we're giving them options for treatment that were really not known, 30 or 40 years ago. So I've shown you guys some really cool images and shown you how IR contributes, to the actual liver cancer team. Okay. And so we're kind of changing this whole paradigm about radiologists don't see patients, because we see patients in clinic, we round on patients, patients know you as their doctor. So you'll get to know the whole IR team, and we sit at the tumor boards with doctors like Dr. Singhal, Dr. Shea, Dr. Rich. And so we're all part of the interdisciplinary team. Okay. So we're all working together to kind of get these people healthy and hopefully to a place where their liver cancer is treated. So thank you guys so much, and I appreciate it.